Hello, everyone. This is Prateek Sharma from Kansas City, and I'd like to extend my thanks and congratulations to Dr. Sahu and Dr. Avinash for this midterm conference. My task is on screening and surveillance practices in patients with Barrett's esophagus. So let's look at screening and diagnosis, which is making the initial diagnosis of Barrett's esophagus, and then once a diagnosis has been made, you enroll patients in surveillance programs based on the progression rates from no dysplasia to low-grade, high-grade dysplasia and cancer. So let's start off first with making a diagnosis of Barrett's and the initial screening endoscopy, which is done in this patient population. So for screening, you should ask these questions. What is the prevalence of Barrett's esophagus in your practice? Who should you consider screening for Barrett's esophagus? And then once you answered those, does the patient on endoscopy truly have Barrett's esophagus for you to be taking biopsies? So let's try to address these one at a time. So the first question is about the prevalence of Barrett's esophagus. This is a very recent publication looking at the global or the worldwide prevalence of Barrett's esophagus and comparing the East versus the West, and it's important to recognize those differences. So looking at 80 studies from the general population and 23 studies in patients who had GERD symptoms, what they found was that in the general population, the prevalence of Barrett's esophagus in the East, including India, would be extremely low, close to 0.5%, as opposed to 2% in the West. Similarly, if you look at the GERD population, the prevalence of Barrett's esophagus is higher. And again, there's a roughly twofold difference with 5% prevalence in the East compared to 10% in the West. And so this gives us a generic idea about the prevalence of Barrett's esophagus in different parts of the world. Now, focusing on Barrett's prevalence rates in Asia, the study by Dhawan and colleagues showed a prevalence of 6%. And this is very similar to what we just discussed about Barrett's prevalence of 5 to 6% in those with GERD patients in the East. What's been happening to the prevalence of Barrett's esophagus over time? This is again a recent study from Diseases of the Esophagus, looking at one single center in the US, more than 1,100 patients with GERD who were studied from 1998 to 2015. And if you look at the prevalence of Barrett's esophagus shown in blue, what this study showed that there is now a decreasing prevalence of Barrett's esophagus from the 1990s to 2015. And during the same time period, there has been a significant increase in the use of acid suppressive medications, specifically here proton pump inhibitor medications. So whether these data are true for India or Asia still remains to be shown, but giving us a snapshot that perhaps better acid control may be leading to a reduction in the prevalence of Barrett's esophagus in the patient population. So who should you consider screening for Barrett's esophagus, meaning that you're performing the initial screening endoscopy? And these are some risk factors for having Barrett's esophagus. Reflux symptoms, we've already talked about that. Central obesity is an issue, smoking, and as the age increases, the prevalence of Barrett's esophagus also increases. So these are some risk factors to keep in mind. You can see from all these society guidelines, and these are again mainly from the Western world, the ACG, AGA, ASGE, and then the British Society of Gastroenterology, all of them recommend against general screening, meaning starting, let's say, at age 50 in the general population, but they talk about targeted screening, and that targeted screening should be performed in the population. However, when we look at the Asia Pacific Consensus Conference, it recommended that there was no value for screening in the Asian Pacific region due to low prevalence rates and lack of benefit, which goes along with the low prevalence of Barrett's esophagus in India, for example, which was highlighted in the study. Finally, once you are performing endoscopy for some indication, does the patient truly have Barrett's esophagus? And if they do, you should characterize or grade them using the Prague C and M criteria based on the circumferential and the maximal extent of Barrett's esophagus. So look at the gastroesophageal junction, which is highlighted here, which is the junction between the esophagus and the stomach, and then measure the circumferential extent of Barrett's esophagus, which is shown here, and the maximal extent of Barrett's esophagus shown here, giving you the C and M value for Barrett's esophagus of how to grade patients with Barrett's esophagus. Now, during endoscopy, it is critical that we know what this means. And here is a tongue of Barrett's esophagus above the gastroesophageal junction, a C0M2 Barrett's esophagus, whereas on this other endoscopic picture, what you see is that there is no Barrett's esophagus. So try not to take biopsies in this patient. I'm showing the X where you may be tempted to take a biopsy, but avoid taking a biopsy. That's not Barrett's esophagus in that situation. Once this diagnosis has been made, patients need to be enrolled in a surveillance program for detecting dysplasia or early esophageal adenocarcinoma. So these are the questions. Are you inspecting the Barrett's carefully? Are you taking adequate biopsies? And finally, are the surveillance intervals appropriate in your patient population? So let's look at the first two things. And this is important because cancers can be missed in patients with Barrett's esophagus. This is a study from the Mayo Clinic in which they looked at a meta-analysis of several studies and looked at cancers within Barrett's diagnosed in a year of the diagnosis. So at the index endoscopy, no cancer was reported, but within a year, cancer was reported. So this probably means that the cancer was missed. And what they determined was that up to 20 to 25% of all cancers were diagnosed within 1 year of the index endoscopy. So it tells us that we are probably not doing a good job in examining the esophagus and diagnosing cancer. For example, this is a patient with early adenocarcinoma. At the 12 o'clock position, you can see a nodule, and this is an early adenocarcinoma in a patient with Barrett's esophagus, and it's critical for us to recognize these subtle lesions which can be missed. Barrett's inspection time. So spend enough time in the esophagus. This study shows that as the inspection time increased from less than 2 minutes to 7 minutes, there was a significant increase in the high-grade dysplasia and cancers that were detected in the patient population. So spend time in the esophagus looking for Barrett's lesions, which can be done. You can use magnification, you can use electronic chromoendoscopy, looking for irregular patterns. And this is the Bing classification, which showed a very high negative predictive value of ruling out high-grade dysplasia or cancer. So you can make yourself trained in these techniques and can increase the yield of finding high-grade dysplasia and cancer in the patient population. What are the surveillance intervals? And these are different guidelines from the US again, which show that surveillance intervals for non-dysplastic Barrett's, which is what you would see mainly in India, should be 3 to 5 years. So don't try to perform endoscopy more frequently than 3 to 5 years if the patient has no dysplasia in a Barrett's segment which is there. However, how good are we at following these guidelines which have been recommended? This is a recent publication on looking at more than 14,000 patients with Barrett's esophagus, close to 5,000 endoscopists who were performing surveillance endoscopy. And you can see that adherence to surveillance intervals is roughly about 50%. Similarly, adherence to a biopsy protocol is also about 50%, which tells us that as endoscopists, we are not good at following the guidelines, and I think we should all try to do a better job at looking at surveillance in patients with Barrett's esophagus. And training can help you. This is a very nice study from the UK in which they looked at two groups of endoscopists. Group A were trained endoscopists who were trained in the Prague classification, the Seattle protocol, how to spend time in the esophagus, lesion detection, whereas Group B were not given the specific training. And you can see that there was a significant difference in dysplasia detection in Group A versus Group B endoscopists, probably resulting from a better biopsy protocol, better lesion detection, as well as spending time in the esophagus. So training is critical, and I'd urge all of you to try to get yourself familiar with all these techniques for esophageal endoscopy, which will help you treat your patients much better. So what's the future hold for screening and surveillance in patients with Barrett's esophagus? Personalized medicine is one. And then again, artificial intelligence, I think, is impacting all areas of gastroenterology and endoscopy. And I think these two things will be critical for the future as we manage patients both for screening and surveillance endoscopy. First, we need to look at what are risk factors for progression. Here's looking at 75,000 patients with Barrett's esophagus. And what they found was that male gender, smoking, increasing length of Barrett's esophagus, and presence of low-grade dysplasia were risk factors associated with Barrett's cancer. So that's what we should be focusing on in patients with Barrett's esophagus and making treatment decisions, personalizing them, rather than assigning one interval for everyone. This is a study from gastroenterology from our unit in which we assigned points based on these risk factors. For example, 9 points if the patient was a male gender. And as the length increased, 1 point was given for every centimeter increase in length of Barrett's esophagus. And based on these, what we were able to characterize patients into low risk, intermediate risk, and high risk. And we showed that the annual risk of progression was significantly different based on these points. So we should be to this point of personalized medicine in Barrett's esophagus. And if somebody has a high risk, they should be treated differently as compared to somebody who has low risk for progression. And surveillance intervals in that group could be extended to 5 years or perhaps in the future, even 10 years because of their very low risk of progression to esophageal adenocarcinoma. The other thing which will help screening and surveillance is artificial intelligence. And this is endoscopy built in along with algorithms, which will show you where the areas of abnormality are and also predict whether there's a 90% chance, 95% chance of that area in question harboring high-grade dysplasia or adenocarcinoma. Studies are still being done in this field, but this will really revolutionize how we perform esophageal endoscopy in the future. So be tuned for these techniques which are coming up. So finally, to leave you with the Asian Pacific consensus, which I think would be very reasonable for the Indian scenario on how to manage patients with Barrett's esophagus. There's no proven benefit in endoscopic surveillance in the absence of dysplasia. However, if you choose to do it, non-dysplastic Barrett's every 3 to 5 years is what should be done. If dysplasia is detected, for low-grade dysplasia, you can actually either treat or repeat endoscopy in 6 months. For high-grade dysplasia or early adenocarcinoma, you can either resect, which would be the preferred treatment, and then ablate the remainder of the Barrett's esophagus. Of course, I've not gone into the endoscopic treatment aspect, but just a global consensus approach on Barrett's management. So again, I'll stop there with my presentation, and this will be followed by the panel discussion. Again, thank you all for having me here today.
Good afternoon. My name is Nitin Jagtap. I am consultant gastroenterologist at Asian Institute Gastroenterology, Hyderabad, India. I would like to thank Dr. Avinash and Dr. Sahu for giving me this opportunity. So my task for today is to discuss about endotherapy for GERD. So why all we are interested in this topic? Because the incidence of GERD is increasing and the worldwide prevalence of GERD based on symptoms is 13%, though there is a variability in throughout the world geographically. However, prevalence in India is more than 25%, and we all know that heartburn and regurgitation are most common or cardinal symptoms of GERD. So we have two types of treatment, that's PPI, which is mainstay of treatment, and surgery, which can be called as anti-reflux surgery as a treatment option. So we all know that PPI are effective in healing erosive esophagitis, and in this LOTUS trial, which is randomized controlled trial of more than 500 patients, it shows that there is significant improvement and PPI are comparable to the laparoscopic anti-reflux surgery. However, regurgitation is the symptoms which is not adequately controlled by PPI. So the patient who is having regurgitation as a prominent symptoms and not doing well on PPI should be considered for other therapies. Also, there is a certain unmet need in this topic because PPI are ineffective in up to 20% of patients. There is some concern about the long-term safety of PPI, though these studies which question about long-term safety are not well designed and appropriately reported, but still there is some concern about long-term safety of PPI. And the surgery is associated with new onset dysphagia, gas bloat syndrome, and diarrhea in up to the 85% of patients. So there is a place where endoscopic therapy can be placed in. So who is the ideal patient for endoscopic therapy in GERD? Patient who is having classical symptoms of GERD, who is dependent on PPI, there is mild or moderate erosive esophagitis, and patient having small, that's less than 2 or 3 centimeter of small hiatus hernia. So there were various other endoscopic therapies which were tried in previous 2 or 3 decades and which came and went off the market because of various reasons. So currently available endoscopic anti-reflux modalities can be divided into 3 or 4 types, which is radiofrequency ablation, transoral fundoplication, mucosal resection, and recently described mucosal ablation. So we'll go one by one. We'll start with Strata. So the Strata uses this MDRF generator, and which used for Strata can be constantly, it can constantly monitor temperature and impedance during the procedures, and it is based on this balloon device, which is having these needles which provides ablation around the GE junction, and it provides around 40 at around 40 different points. It causes ablation of GE junction mucosa, and it's postulated that this radiofrequency ablation acts by remodeling of the tissue and reduces reflux subsequently. However, these two meta-analyses have showed the conflicting evidence, and in absence of good data and properly conducted randomized trials, this technique is not well popularized. Coming to the second treatment modality, which is mucosectomy. So Inouye in this initial, he is described in this pilot study in 12 patients where the around 270 degree of mucosa is resected to cause ulceration, and which subsequently heal by fibrosis and reduces the reflux. The major pitfall for this procedure is intraprocedural bleed, and healing is a natural, unpredictable process. So one can't explain how much healing will occur and at what level. Although this pilot study had shown there is some benefit at 6 months and 12 months in terms of total symptoms reduction and heartburn and regurgitation improvement. Also, there is flap wall grading, which improved significantly at 6 months. So rather than resecting mucosa, can we just ablate with using TT knife or argon plasma coagulation with or without lifting submucosa with saline? And this is also initially described by Inouye in this pilot study, and we've done this study, prospective study, in which we enrolled 29 patients with mean age of around 40. Out of 10 were females, and the mean procedure time was not more than 30 minutes in this procedure without any significant major adverse event. And you can see in this chart, there is significant improvement in quality of life score, total score, heartburn score, regurgitation score at 3 months and 6 months. Few of these patients underwent pH-metry at 3 months, and we could show that there is significant improvement in DMISTer score and acid exposure time at 3 months. We are waiting for these patients to complete 12 months follow-up, and we are waiting for the final results of this study. Coming to the third modality, which is transoral fundoplication. So there are various devices which can do a transoral fundoplication. One of them is Esophagus. Esophagus is similar to the GERD-X device, which create a tight wrap around the GE junction. However, it takes a longer time and requires more pleats than GERD-X device. The procedure time is longer because this fastener has to be traveled transmurally at a specific location. There are various trials conducted with this device. One of them is this TEMPO trial, in which esophagus tip was compared with open label PPI therapy conducted at 7 centers with 2:1 randomization ratio. And you can see there is significant improvement in heartburn at 6 months and 12 months. Also, 82% of patient has reported complete discontinuation of PPI post-TIF at 12 months. However, when we study objective parameter in pH-metry, there is no statistically significant difference of pH normalization at 6 months and at 12 months. Coming to the second study, which is RESPECT study, it was held in 8 centers at US, and the randomization was between TIF and the sham procedure. And this study has a primary endpoint of reduction of troublesome regurgitation, and which shows that there is significant reduction in primary endpoint of regurgitation as compared to the sham procedures. Coming to the third device, which is full thickness endoscopic plication device available in India, and recently AIG has published this study into the prestigious GERD journal. And this study is the primary endpoint. There is more than 50% reduction in GERD HRQL at 3 months, which is observed in around 65% patient in GERD-X arm compared to only less than 3% in sham arm. Also, there is significant reduction in total HRQL score at 3 months, 6 months, and which is persisted up to 12 months. Not only this, there is significant improvement in heartburn score and the regurgitation score up to 12 months compared to the sham procedures. When we see reduction or cessation of PPI in this patient, you can observe in the Kaplan-Meier curve, there is significant reduction in PPI resumption in patients who had GERD-X procedure as compared to the sham procedure. Coming to the objective parameters on pH-metry, there is no significant difference between acid exposure time. However, the total reflux episodes were significantly decreased in GERD-X arm compared to the sham arm. Coming to this third device, which is called Muse device, is Medwiz endoscopic stapling device, and we are showing this procedure in this video. You can see it's a disposable endoscopic system that creates 270-degree anterior fundoplication using surgical endostaple using ultrasound waves, and is deployed about 3 centimeters above the GE junction. You can see in the last photo how the classical anterior wrap is formed after the Muse procedure. There are 2 studies published with this device, but none of them is RCT. Both are multi-center observational study of single arm. And this first study, which reported more than 50% reduction of PPI in GERD HRQL score, has been published in 2015, and subsequently this year A 37 patient study was published with 20 patients completing 12 months follow-up. There was one severe adverse event, which is esophageal perforation. And this study shows there is significant improvement in GERD, HRQL, heartburn score, and regurgitation score, along with significant reduction in PPI intake in patients who underwent Muse procedure. However, similar to other studies, other devices, there is no significant improvement in pH parameters on 24-hour pH impedance metry. I will come to this last point, which is FDA approved magnetic sphincter device, which can be placed by laparoscopically around. Bottom line of this study is that it reduces PPI intake up to 10% at 3 years, and significant reduction in severe or moderate degree regurgitation, and patient is also well satisfied with this procedure, and this procedure is being slowly replacing anti-reflux surgery. Not only this, but this procedure has also showing objective evidence in terms of pH manometry, that acid exposure time is decreased, total number of reflux episodes are decreased, and DMESTER score at 1 year is also decreased. So the main clinical situation where this endoscopic anti-reflux therapy for GERD will be really helpful in patient who is having prominent regurgitation as their symptom, patient with symptoms due to non-acid related reflux where PPI usually don't work, patient who are having prominent extraesophageal symptoms of GERD, patients who had failed anti-reflux surgery, or those who are concerned about long-term safety of PPI, especially women who are in the reproductive age. Still, data is evolving in this topic, but there are few promising literature about GERD-X and ARMA is being published in recent time. Thank you very much.
I thank you so much, Nitin, for an excellent presentation. Lecture by Dr. Sharma, as usual. So I welcome all the panelists here for today's discussion, Dr. Rachita, Dr. Srihari, Anikandi, and Dr. Lokesh. And I also welcome all the chairpersons for this event as well. So I think just to kickstart the discussion, Rachit, if you're there?
Yeah, hi, Dr. Sharma.
Okay. Hi. Sorry, my internet connection is unstable. But just going back to the Barretts presentation. So in India, do you end up using advanced techniques like imaging or chromoendoscopy from different manufacturers evaluating Barrett's lesion repeatedly? And do you think there's any advantage of chromoendoscopy over white light regular endoscopy while you're screening for Barrett's?
Yes, absolutely. I think there is a marked difference when you are using chromoendoscopy. We know that when we are using a Seattle protocol biopsy with only white light endoscopy, only about 4 to 5% of the surface area is actually sampled. Particularly the neoplastic tissue or the focal areas of high-grade dysplasia may be embedded below. So using newer modalities like the chromoendoscopy or virtual chromoendoscopy, it is much better to able to delineate the areas of high-grade dysplasia. You have the Bing classification, which Dr. Sharma showed, and it helps us in deciding the base of the pit pattern and the vascularity as to which are the areas of high-grade dysplasia and even malignancy, which helps us in the pickup rate and makes a marked difference in the surveillance of the patient and overall outcome of the patient.
Great. Oh, thank you. And I think, as you see, in India, in busy centers if you can't give sedation, I think oftentimes I feel Barrett's is probably missed. And I think we need to underscore the importance of actually doing a very careful white light examination, especially to find these plastic lesions, which can be easily missed, right?
Yes, you're absolutely right. The prevalence is apparently quite low in the Asia Pacific region. We don't know whether it's due to lack of actual surveillance or it's the actual data. So maybe spending much more time in an endoscopy suite would be better, and maybe you'll be able to pick up more lesions.
Dr. Saurabh, if I
Right.
could
Thank you, Rajat. Yeah.
Yeah,
Nitin,
so what I would like to know is whether we could completely do away with the Seattle protocol and only utilize NBI for screening such patients, or would this be complementary to using the Seattle protocol and we use NBI in addition to doing taking the biopsies as per Seattle protocol?
Right. No, I think that's a good point that you made. We're probably not getting away with the Seattle protocol as of now, but I suppose you do a really careful high definition white light examination and using chromoendoscopy or NBI, you should be able to pick up some LGDs and definitely high grade dysplasias and cancers. But it'll be interesting to see if you can do away without it and see, because you're sampling. Obviously, it's random samples and it's a small surface area that you're covering. All right, good. And Srihari, okay, now just moving on to you. Do you think in terms of endotherapy for GERD, I think it's very exciting and we have such a large population which needs it. Can you give some comments on, pre-endotherapy? What sort of evaluation do you recommend? pH metry, manometry? Please go ahead.
Yeah, I think Dr. Prateek Sharma and Nitin already touched upon the basic points, the basic population which needs to undergo screening for any complications arising out of GERD. So it would be a typical patient who has long-standing history of GERD, most of them obese, possibly, with maybe family history of Barrett's or an adenocarcinoma. So endoscopy is mandatory in all these patients. Things that we can look into with endoscopy is one, presence of reflux esophagitis, which could be classified according to the LA classification. So according to the Los Angeles classification, C and D are definite reflux esophagitis. A and B might or might not be reflux. The second thing that we need to see is the presence of a hiatus. Patients with significant hiatus hernia might not be the right candidates to undergo endotherapy, and they might be better candidates to undergo a surgery. Apart from endoscopy, other things that can be looked into with the endoscopy, as we just discussed, is the presence of a Barrett's or presence of dysplasia, either with a high definition white light or by using NBI and biopsies. After the endoscopy, for objective classification, it is essential that we need to have a pH study in all these patients. So I would like to make a distinction that we have availability of a simple pH study and we have a pH with impedance study. So for documenting the patient as having reflux, the guidelines state that you need to stop the patient on PPIs, and using a simple pH study would be the gold standard for documenting abnormal reflux in these patients. So high acid exposure time is the criteria that is used by most of the studies to fit into these patients who have significant reflux. The role of pH and impedance study comes in those patients who are already diagnosed with GERD and they are on PPIs, but they are not responding. So to find out whether the patient has a component of functional heartburn, that is when the impedance study comes into play. It is not necessary in all patients to document a reflux. The third thing that is important is also doing a esophageal manometry. Things that the places where esophageal manometry has a role in management of these GERD patients is one, to see for the adequate placement, the appropriate placement of the pH probe, because we have to place the pH probe 5 centimeters above the manometrically documented LES. It has to be done through manometry. It cannot be done under fluoroscopy. It cannot be done with an endoscopy. It has a connotation because it is at 5 centimeters where we will be able to catch most of the refluxes coming from the stomach. If you place the catheter too high, most of the refluxes would be missed. If you place the catheter too low, you will be naturally going into the stomach and you will be having abnormally high readings. So one place where manometry helps is localizing the place where you want to place the pH probe. Second thing that is seen is a small hiatus hernia.
Small hiatus hernia usually can be missed with an endoscopy. Manometry is a good technique to find for small hiatus hernias. Third thing is to see for esophageal motility. So if you have a significant esophageal hypomotility on your manometric studies, so in those cases, going in for a complete 360-degree fundoplication might not be the right thing to do, because it is very likely that these patients will end up with dysphagia. So in these cases, it is better to go in for a partial fundoplication. I'm not sure whether manometry would be warranted in all patients who intend to go in for a endotherapy, because with most endotherapeutic options, you don't go in for a complete kind of fundoplication like a picture, but our guidelines on this are still not very clear. Another place where manometry could be useful is to see if there are any underlying other reasons for GERD, like ruling out an achalasia cardia, or ruling out any esophageal motility disorders like a spastic esophagus who are presenting to you with recurrent chest pain. So these are the places where manometry is useful. So every patient who is planned for a surgery or an endotherapy prior to for GERD should undergo an endoscopy, a pH study, and esophageal manometry prior to these procedures. Yeah. So Nitin, if I could just ask you a question, what would be the cautery settings that you use while you go in for an ARMA?
So that's very good question, and I actually missed that in my presentation, I think. At our center, we use argon plasma coagulation. Initial few cases we did with TT knife, but now we are shifting to APC, because that's most commonly available and that can be done by all gastroenterologists. So we use 100 watts at flow of 1, and effect size is around 3 for the force APC coagulation at during ARMA. Additional point that we initially used to inject into the submucosal plane saline with the methylene blue, but after 10 cases, I think we stopped doing it, and we're directly doing APC now. That's one thing. And additionally, when you are doing APC and this procedure takes around 30 minutes, your stomach gets distended, and due to that gas, your vision is also get obscured. So we advise to use a larger therapeutic scope, 290 series, which having more than 3.5 mm of channel, so that the suction will be more efficient, and your procedure time will be maintained less than 30 minutes. So that 3-4 points that one should remember when you are doing ARMA procedures.
Hello, Nitin. Excellent talk, Nitin. One thing, Nitin, you do entire procedure on retroflexion view, or you use antegrade also?
It's in the retroflexion only, majority.
So your APC probe is very close to the scope. So yes. How about the scope injury?
So we need to avoid that initial few mm's of tissue, so that the scope injuries should not be occur. So you have to be cautious during that procedure.
Nitin, apparently Professor Inouye had proposed this procedure by using a TT knife, and they had also done submucosal injections in these patients, apparently with an intention that you need to have deeper burns so that the fibrosis is better. I would like to know, with your experience with this APC, which usually tends to cause only superficial burns, not very deep, have you been able to achieve a good constriction of the lax ileus with these procedures?
Yes, that's very good question. The initial description was with submucosal injection, and the recent publication from Mexican group, which is just now published in GIE, they have also used the submucosal injection. But in our initial few cases, we found that there is no significant difference in terms of patients' symptoms reliefs and at acid exposure time at 3 months. So we progressively stopped doing a submucosal injection. Coming to the second part, which can cause more submucosal, which can more fibrosis and healing. I think if we separate submucosa, then the chances of getting significant fibrosis will be decreased. So, but that's not translated into the clinical endpoints. So we are not using submucosal injection at now. Also, you asked some other question. I just forgot it. Sorry.
No, the efficacy of the procedure that you
both procedures, both either doing submucosal injection or not doing submucosal injection, I think both are doing equally good. And not doing submucosal injection can reduce your time, so you will get a procedure finished in early time.
Okay, so you also mentioned about Esofix and GERD-X. So Esofix and GERD-X are working on a mechanism which is slightly similar to ones available previously, like EndoCinch or Plicator, where there was suturing. But those devices are now no more used, possibly because of the adverse events. So how has been your experience with these GERD-X and Esofix?
So,
do you see a future? Will these devices stay for long?
So the Esofix we don't have in India, and we personally don't have experience. Coming to the GERD-X, so the regarding the major adverse events, the first major adverse event that we recognized was the pleural effusion that required therapeutic paracentesis. And in our recently published RCT in gut, we have shown that this is not a major side effect. In majority of patients you don't see it, but one patient required a therapeutic paracentesis in our group.
Okay.
So at 1 year follow-up, we could show that there is significant improvement in patients' quality of life. Also, there is significant improvement in number of reflexes. However, so acid exposure time was not significantly difference between GERD-X and sham group. And I think that goes with other devices also. Except this recent publication that from Mexican group, which has had more than 100 patients, they have shown that there is decreased in the acid exposure time at up to 3 years in 84 patients. So we need to see in our population also how they are behaving after long term.
Dr.
Nitin,
Lokesh,
I have one question.
Okay. Yes, Dr. Lokesh.
Yeah, Nitin, I have one question. See, when you take you have 3-4, types of endotherapies. When you choose a type of endotherapy, like you have any preference for one particular endotherapy for one particular set of patient, based on the hiatus hernia, based on the other parameters?
It's very difficult to say now in absence of
any preference of one
trial, but comparing between GERD-X and ARMA, we have observed that those patients who are having more number of reflux episodes do well with GERD-X compared to the ARMA. So if on pH-metry the number of reflux episodes are more, then we prefer GERD-X, but we need to study that in detail. So I can't recommend which procedure to be follow in which patient. But if there is large hiatus hernia, these patients are not candidate for endotherapy. You should refer them to the surgeon.
Dr. Lokesh, would you prefer doing an endotherapy in patients who have non-erosive reflux disease? Because most of the findings have been that the appropriate patient would be those patients who are responding to PPIs and possibly patients who are having erosive esophagitis. So would you recommend endotherapy as an option for patients who have non-erosive reflux disease?
When you see the NERD patient, most of them, they won't respond to the PPI as per the data. 40% when it comes to erosive esophagitis, 60 to 70% will respond to PPI. But in case of non-erosive NERD, they won't respond to PPI. But depends upon, we need to evaluate, as you said, like, hello, I'm audible?
Yes.
Hello?
Yes.
Hello? I'm audible. Okay. When if it is a non-erosive reflux disease, we need to evaluate other causes. Like, as you said, like you need to subject them for the endoscopy impedance studies as well as the pH manometry. And you need to categorize them whether they're truly NERD, whether they have a reflux or not. Or then second point is we need to make sure whether the patient is having a reflux episode but keeping the acid exposure time less. So we categorize them into whether the patient is reflex hypersensitivity or NERD, or categorize them into functional heartburn. So functional heartburn, definitely there's no role for endotherapy. And it regards to NERD, definitely there's a definitive role. In case of reflex hypersensitivity, first we need to treat them with other medication like tricyclic antidepressant, SSRIs, trazodone. If they're not responding, then even in them there is a role of endotherapy. But our experience with endotherapy is less. Nitin should comment whether how many of them with NRD category underwent endotherapy in their.
Those patients who are classical non-erosive reflux esophagitis are not good candidate for endotherapy in absence of pH metry showing not showing any significant acid or non-acid related reflux. So better you avoid them to be a candidate for endotherapy in this patient.
Hello. So I had actually few questions or queries to ask regarding the surveillance and of Barretts Esophagus. So we actually basically know that in our country we do not get as much Barretts Esophagus like in the Western population. Hello. Hello. Am I audible?
Yes, sir.
Yes. So what we see in our setup actually, we see quite a lot of cases of short segment Barrett's who are never symptomatic. They are incidentally detected. So what should be the surveillance methodology or criteria in our country especially? Because when we see a short segment Barrett's, which is less than 1 centimeter, relatively younger people, educated people. So how do we take biopsy? Sometimes biopsy are indeterminate, or sometimes they might show a low-grade dysplasia by some pathologist and indeterminate by some other pathologist. So people usually that gives a lot of fear in the patient regarding the development of future carcinoma, everything else. We know that short segment Barrett's are followed up not very frequently. If they are not dysplastic, they are followed up every 3 to 5 years. If they have a low-grade dysplasia, what should we advise to those patients? Low-grade dysplasia, short segment Barrett's, asymptomatic, no GERD symptoms, and relatively younger patients in our setup. How should you go about? Any of the panelists?
Thank you. So I just want to mention that the low-grade dysplasia needs to be confirmed by pathologists. I think really the crux of the matter is that confirm.
No, we'll confirm the Barrett's by doing the biopsy. We see the intestinal metaplasia. Okay, so we confirm the Barrett by histopathology, but there is no dysplasia, and usually it is less than 3 centimeter, maybe 1.5 centimeter, and patient had no symptoms at all. Go about how do you follow them? How in those cases? So how do we advise those patients?
See, I think if you confirm low-grade dysplasia and you're sure it's low-grade dysplasia, I think endoscopic eradication therapy should be offered with RFA if that's available. Or an option reasonable can be, surveillance biopsies in these patients to ensure that it's not progressing to high-grade dysplasia. So these are the two real options for you. RFA may not be easily available in India, so that may be something that you may not be able to do locally, may need a referral. But I think that's a preferred approach. Surveillance to ensure it doesn't progress to high-grade dysplasia or cancer is an option which can be done with frequent interval biopsies. But RFA, if you can, or any other modality would be something you should try. Maybe APC in India may be considered, but I think RFA is preferred. And then, of course, any visible lesion needs to be dissected. I think that's crucial that it's done.
Yeah. Thank you.